I would also like to continue our theme with Sentinel and its abundance of riches to introduce our next speaker, who really doesn't need an introduction, I think, to this group. He's been a critical part not only of these annual report meetings on Sentinel, but especially on the core work of Sentinel itself, and that's Rich Platt. Rich is the professor and chair of the Department of Population Medicine at Harvard Medical School and executive director of the Harvard Pilgrim Healthcare Institute, and has been from the start the principal investigator, the source and core of the vision, and all of the large amount of energy, commitment, time, and effort that have gone into bringing Sentinel to the point where it is today. And I'd like to hear from Rich about his views on updates from the Sentinel Coordinating Center. Rich?
In Mark's introductory comments, he noted that Sentinel has established quality-checked, curated, and unduplicated data, and it took about 2.5 seconds to say that. But one of the dogs that won't bark today is the fact that we're not going to spend much time talking about the extraordinary accomplishment of creating a distributed data set for which we have a pretty good idea of its capabilities and its limits. And that was the work of several years. Those who've attended this meeting over the years know that we spent a very considerable amount of time and energy just talking about the work that went into creating this kind of resource. Because reflect on the fact that we live in a society that that doesn't automatically create the kind of data that's useful for FDA's decision making, and it has taken the work of literally hundreds of people to be able to create the resource that now we're talking about the fact that we wish we could use it faster and turn it around more. So there's a lot to sort of that's just under the surface of the things that are appropriately the topic of today's discussion. I have some slides. Do you think we could bring them up, please? I will sing from the same songbook that Rich Mashitsky started us off on, and frankly, I'll just go a little deeper on his comments, the comments of Gerald and Steve. First, I want to make sure to call out the many organizations that participate in Sentinel. You can see them here. A number of my colleagues are in the room. Can I ask you folks just to stand up for a second, partly so that you can get some credit. Okay, everybody, up you go. Partly because they're your best source of sort of comments and questions if you want to talk during the break. So thank you, folks. The Sentinel Common Data Model is here. It was designed. It is a remarkably simple model. Why is it a simple model? It's simple because these are the data elements that the several data partners agreed that they could create in a way that would be consistent across them. Mike, let's talk later. The data model is detailed, is on the website. Considerable detail on the definition of the variables, and the modular programs are on the website too. So I want to make sure that everyone knows they are there. They are not. We'll be the first to say they are still not very, very user friendly. It takes a fair amount of knowledge to use them to their fullest extent. But it has been our charge and our desire to make these tools available to everyone. Just top-level tables are ones that every data partner populates. The bottom-level tables are ones that some data partners populate. One of the keys to success of Sentinel has been the fact that we've never had to ask data partners to provide their data. We've always been able to send the questions to the data partners. one of FDA's instructions to us as we were beginning to think about Sentinel was to say, FDA does not want to take possession of individuals' data. And that was a really important foundational instruction from FDA. FDA is not in the business of having people's private information in its possession. And this mechanism has really sort of undergirded a great deal of what we've been doing. So the questions in the form of executable programs go to the data partners. They can decide whether they're prepared to respond to those questions. Everything is opt-in, and then they return those. Rich Masiski gave us this sort of high level of what's in the data set. So there's a lot of information, and we think we understand how to use it well. These are the key elements. The fact that Catalyst, FDA Catalyst, is a new addition has really made us think about what's Sentinel and what's not Sentinel, because the infrastructure can support a substantial amount more than it's doing. As Rich Masiski said, it was at the last meeting that Janet Woodcock said it's a integral part of routine safety. And we have been trying to be attentive to these two mandates. One is stand up the production capabilities of Sentinel to be able to support decision making, and then develop these additional capabilities. Let's pause for a second on the protocol-based analyses, which Steve Anderson particularly highlighted. Over the years, we have talked about a number of Sentinel's important successes, the ability to closely replicate well-known findings of ACE inhibitors and angioedema, or study of rotavirus vaccine and intussusception in infants that guided regulatory decision-making. And those are examples of protocol-based studies. They were and are a big success. It's possible to do a protocol-based analysis in a year, maybe 2 years, and it costs $1 million or $2 million. And you say, what kind of success is that? And all I'll say is, if you lived in a pre-Sentinel world, the studies that take a year or two and cost $1 million or $2 million used to take 3 or 4 years and cost $7 million. However, that's not the basis of the kind of obligations that FDA has. But Christian Hamp this afternoon will talk about a protocol-based analysis that Sentinel has done, and there will always be a place for protocol-based analyses. But the ability to be able to answer questions quickly and efficiently really depends on what we're calling the routine analytic framework that supports these active risk identification and analysis programs. And for that, we have been, over the years, developing an ever more capable set of tools that support these. So Sentinel now has 3 ways to address questions. There are these custom programs that support protocol-based analyses. You put together a group of experts. They think about how to answer the question. They design the programs. We figure out whether the data is really up to it, and that takes a year or 2. Routine analytic framework are these programs that they're canned programs. You specify the population of interest, what they're exposed to, and the outcomes of interest, and they're very quick and efficient. And we found that it was very hard to match these programs to the specific questions that FDA staff needed to answer. And so over the past year, we've developed a hybrid, which we call RADAR, the Rapid Analytic Development and Response Capability. Start with a modular program and do a little bit of custom programming on top of that. So the rule of thumb is it can be a radar activity if 8 hours of programming will provide the additional kind of information that FDA staff needs to be able to make effective use of the program. And that has really unlocked a lot of additional functionality for us. So here's the sequence. This is what you can do with these modular programs. We can do simple counts of things. So and it goes from least complex to most complex. Very simple counts. Sometimes the question is there enough of this product being used that it's worth even asking the question? Or are there enough outcomes of interest that it's worth asking a question? If you wanted to know how many people under 35 have a diagnosis of cataract, we pulled out of the simple queries. So that's these. And in the last year, we had 49 of these queries, several hundred scenarios. It's the kind of information you ask before you spend the additional resources to do more. These complex counts actually provide substantial information about who's exposed to what and what happens to them. So now we're talking about actual, not just counts, but actual rates. How much person time is there? How long were people exposed? Who were they? We can qualify them by saying we want first diagnoses of heart failure among individuals exposed to different drugs that are used to treat ADHD. This is an example that Andy Musholder will talk about later this afternoon. This is a level. So this is a complex count query. Rich Mashitsky and I'm way behind. Rich Mashitsky and Gerald talked about level 1 programs. That's what these are. And you can do a lot sometimes by just doing these counts. Here's an example of a look at the use of antiemetics in pregnancy. FDA just asked us to use a level 1 program enhanced by a pregnancy tool to look at the use of antiemetics. And here's a drug, ondansetron, not approved for use in pregnancy, which turns out is being used for almost a quarter of pregnancies that come to term. And this is work that Lockwood Taylor led, and the conclusion is we probably ought to know more about whether it actually works to treat nausea and vomiting in pregnancy. And we might need to know more about the safety of the product. Rich Forshee will talk about looking at blood transfusions during pregnancy. This became of critical interest about a year ago when the question was if there might be Zika virus transmitted by transfusion, how important is that to pregnant women? We had, the thing I really want to point out to you is that it was a priority request and we were able to return high quality data in 3 days from 15 different data partners. Sometimes you want to compare the rates of events. These are so-called level 2 programs. These are adjusted rates or hazard ratios or self-controlled risk intervals. And the work that this afternoon that you'll hear about on risk of seizures associated with ranolazine is an example of this. We can keep about 16 to 20 of these complex queries going at any one time. And the reason for that is although these are highly automated programs, there's a lot of discussion about ensuring that you frame the question exactly in the right way. Then there's often follow-up questions. It had been the case that if you needed to know more about an individual, you would go get the record, and we do a fair amount of that. And as Steve Anderson pointed out, it's slow and it's expensive. And so as an intermediate step, we've created a patient episode profile report that allows you to put together all of the information from these individuals in a way that a human can read them. So on day 0, this infant was immunized. 4 days later, came back to the office with gastroenteritis, and 3 days later was hospitalized again with gastroenteritis and dehydration. This gives you a sense of what was actually happening. These queries have been used to look at medication errors and geographic location stratification. We don't have time to talk much about how methods development and data expansion work, but it's a multi-step process to make sure that we know that, let's say that the data are there, that we're clear about how to use them, and then can actually build them into tools so that they can be used on a regular basis. Rich talked about the fact that there are 4 data expansion projects. I particularly want to highlight the CMS expansion because within a few months, we'll effectively double the size of Sentinel to be able to use these tools with the CMS data. These are selected methods that are being developed by during this past year. We've put a fair amount of work into communication. Steve Makita will talk about the patient engagement piece, but another big piece of that has been redesigning our website to look like this. And I want to spend the rest of my time just giving a sort of a quick intro to the work that of what is evolved into the National Evidence Generation System, EVGen, that FDA is leading. Last year, we talked about the fact that in additional Sentinel, IMEDS was trying to do some work. The NIH Collaboratory had great progress. There were opportunities for collaborations with PEPR. CDC was interested in using this, and we were thinking about doing a randomized trial. And there's been substantial progress on all of those. We'll hear about the IMEDS program this afternoon from Robert Reynolds and David Martin. This is one of those studies that's already been done, by the Pfizer project that has already been mentioned. With the NIH Collaboratory, we are currently soliciting queries from the scientific community to use Sentinel infrastructure to address questions of interest to NIH investigators. It's on the website now. Please tell your colleagues if they want to do that, because NIH is funding that. With PEPR, Rachel Florence will talk about the fact that there are two projects called Genesis that are partnerships between PEPR and Sentinel, one looking at methods for Zika virus surveillance, congenital Zika surveillance, the other looking at inpatient antibiotic utilization and the ability to report that to CDC. And finally, a Sentinel CDC work group has been looking at medical countermeasures and the ability to use medication dispensing as a proxy for influenza activity. Steve talked about the fact that we would like data sooner, and most of the time when we accelerate the time period, the quality of the data deteriorates. So the reason that the interval is what it is that it seems to be a good trade-off for many things. In this case, the medication data is available much sooner, and so these data can be available literally within a week or two. I'll say a little about the Catalyst activity. We are expecting in April to randomize about 35,000 people in 5 health plans to a direct-to-member intervention to encourage people who should be anticoagulated because they have atrial fibrillation to begin anticoagulation. It's been a working group that's been highly successful, including FDA and the Clinical Trials Transformation Initiative. These are drafts of the kind of mailers that will go out to these individuals. And our hope is that we can substantially reduce the burden of strokes related to atrial fibrillation by this kind of intervention. I should mention we're also writing to the providers to tell them that we've reached out to their patients. And finally, I want to close with a market-based analysis of Sentinel's value. This is the old Sentinel, the Mini Sentinel website, and you remember that while we owned minisentinel.org, minisentinel.com was out there for anyone, and it was for sale for $1,900. And I thought that was pretty good. We're now sentinelinitiative.org, and here's sentinelinitiative.com. It's $3,700. So not only does FDA think it's worthwhile, but it makes a difference. I do want to say that several people have said there are a lot of people who make Sentinel successful, and I just want to shout them out. This is the operations center staff. The tall guy in the middle was the commissioner who came to visit one day. And these are the people at all the sites who have made Sentinel what it is. So thank you very much.